I see we have 60 participants, so we will start right on time. My name is Karen Shaw, and I'm a member of the Alumni Relations Office in the School of Public Health. What we hope to do with this program is to open the classroom to give you a refresher course on the latest research and thinking on critical public health issues, and to hear from those of you practicing public health. We want to begin a dialogue with you, our graduates and friends, so this will be a 30-minute lecture followed by 30 minutes of questions and discussion. We are using a program called Illuminate Live, and I saw some of you already playing with some of the features, so you're getting familiar with the system. That's good. This allows multiple online users to simultaneously view the same computer desktop images while listening and talking to other users. If you have a headset with a microphone, you will be able to ask questions orally. If not, that's not a problem either. You can type your questions in the text box in the middle of the left-hand portion of your screen. You can type them as they come up during the lecture, or wait until the question and answer part of the webinar. Above the text box and just below the participant box, you will see a number of emoticons. There's a hand which you can click and raise if you have a question, a smiley face if you want to give Dr. Kaminski some positive feedback. We encourage that. A confused face, hands for applause, and a thumbs down. Feel free to use these and give us feedback throughout the lecture. Our first lecturer is Dr. Gerald Kaminski. He's one of the nation's leading experts in health policy. He has been reading between the lines of the more than 2,000-page healthcare reform bill. He's going to talk about what's in it and what it means in terms of healthcare delivery and financing. Dr. Kaminski.
Thank you very much, Karen. It's my pleasure to be here today on this webinar to talk with you about what I believe is the most important piece of health legislation that we have passed in the United States since the enactment of the Medicare program and the Medicaid program in 1965. And so what my goal today is to talk with you about the basic rationale for the bill and the major provisions of the bill. As Karen alluded to, the bill itself is an enormous document, and as all of you know who work in the field, there are so many provisions. The bill was enacted in March, and there is now a cottage industry growing around trying to understand the many aspects of this legislation. Obviously, in a 30-minute talk, I'll only be able to just scratch the surface and give you the highlights, but I hope that we have a lively discussion today and that you have lots of questions. So let me launch into my presentation. Let me start by talking about what the major elements of this bill are. This is Public Law 111-148. It's the Patient Protection and Affordable Care Act of 2010. And the best overall summary of what is contained in this bill is that it provides a number of provisions that deal with the currently uninsured population in the United States. And these provisions largely go into effect in 2014. And this is really the heart of the bill. And the major components of what the bill will do for the currently uninsured is three things. It will provide subsidies to make health insurance more affordable to low and middle income families and individuals who are uninsured. It will require mandates for all individuals to have health insurance, and the purpose of these mandates is to prevent cost shifting and free riders from opting out of the insurance system until they need it. And then finally, it will create health insurance exchanges and the purpose of the exchanges is to prevent insurers from setting premiums based on health status and to encourage competition based on standard health insurance policies. And I'll talk in a little bit more detail in a moment about these three components of the bill. Another important aspect of the bill, and this is the patient protection portion of the title of the bill, is that what it does for everyone else, that is everybody who is currently insured. It provides additional protections for those of us with private insurance, and those additional protections begin to be phased in starting this year and next year. It also provides or requires the elimination of pre-existing condition exclusions for current insurance starting in 2014. Finally, it provides protection for anybody who loses their employment-based insurance starting in 2014. So even though a substantial portion of the population is currently insured, beginning in 2014, anyone who loses their insurance and becomes uninsured will be eligible for potentially for subsidies and purchasing insurance through the newly established exchanges that will be in place in 2014. So let me spend some time talking about, in a little bit more detail about the provisions of the bill. So let me start by talking about, sort of in a chronological fashion, what the bill does starting this year. And there are a number of provisions that are going into effect to regulate the current private insurance market. The bill requires that all current private insurance policies do the following, starting this year, for the most part. First, policies have to extend dependent coverage for children up to the age of 26. And that requirement was that the coverage be, or that this provision go into effect within 6 months of the signing of the bill, which is actually next week. September 23rd is the 6-month date since the signing of the bill. So beginning in the first policy year that begins after September 23rd, insurers that currently offer what's known as dependent coverage for children will now have to continue to offer that coverage for all adult children of the insured up to the age of 26. And the key here is that the dependent coverage requirement, or the dependency, is no longer necessary. Your children do not need to be financially dependent on you as a parent in order to qualify for this coverage. The only requirement is that they not be employed and have their own employment-based insurance. The other point that I want to make about this coverage, and one source of confusion right now, is that there is the potential that some children will have a gap in coverage as a result of this new provision, depending on whether they're turning, for example, age 23. Most employers, and UCLA is a good example, currently provide dependent coverage up to age 23. A child turning age 23 between now and the next policy year, which at UCLA starts in January, could potentially become uninsured for a short period this year before this law actually goes into effect for an individual employer. But this is the rationale for this provision, is that it provides coverage to a large portion of the population that is currently uninsured. The bill also eliminates pre-existing condition exclusions for children ages up to age 18 within 6 months of enactment of the bill back in March. It eliminates policy rescissions and the practice of insurance companies of basically eliminating insurance coverage for individuals once they become sick by going back and looking through their applications to find a reason to deny coverage based on alleged lack of information or inaccurate information provided in the application. It eliminates lifetime and quote-unquote excessive annual dollar limits on benefits. The lifetime limits, which many insurance policies have, will no longer be allowed under private insurance. And excessive annual dollar limits are to be determined. The Secretary of Health and Human Services is required to issue a report defining what excessive annual dollar limits are. The bill eliminates cost sharing for preventive services, and specifically all preventive services that are listed by the U.S. Preventive Services Task Force and have received a grade of A or B. Insurers will no longer be able to charge co-payments for those preventive services. Another provision of the bill that is not very widely known is that it provides for rebates to employees if the insurance company's medical loss ratio is less than 80% for firms up to 100 employees, or less than 85% for firms with 101 or more employees. And this starts in January. So this provision is to prevent insurers from collecting premiums and not paying out a minimum amount, a certain threshold amount, I should say, in terms of health benefits. Insurance companies that fail to meet these thresholds will have to provide rebates to their members in order to meet these thresholds. The bill also eliminates waiting periods for coverage that are greater than 90 days. It eliminates annual dollar limits on benefits and pre-existing condition exclusions for all ages effective January 1st, 2014. And then finally, the bill limits deductibles for small firms up to 100 employees starting in January of 2014. Moving on to the individual mandates, penalties, and subsidies that will start in 2014. It imposes penalties for being uninsured of $695 per adult, up to a maximum of $2,085 per family, or 2.5% of household income, whichever is greater. Now, this was obviously, for everyone who followed this, one of the most controversial aspects of the legislation. And as a result, there is a provision in the bill that says that the IRS is prohibited from prosecuting anybody who fails to pay this penalty. So it's an interesting mandate because the mandate requires the penalty, but the law simultaneously prohibits the IRS from prosecuting anyone who fails to pay this penalty. So it remains to be seen how effective the mandate will be, and clearly currently a number of states have undertaken challenges to the health reform legislation specifically around this issue of whether or not an individual mandate is constitutional. The bill provides exemptions for a variety of reasons listed in the slide, including financial hardship, etc. So not everyone will be subject to the mandate, but the vast majority of Americans will be. I should note also that clearly one of the most controversial aspects of the bill was whether the undocumented would be eligible for subsidies and included in the reform bill, and they are explicitly excluded. They are not required to purchase insurance, but they also are not eligible for subsidies and also not eligible to buy insurance in the exchanges that are going to be established in 2014. The bill provides subsidies for individuals and families in the form of tax credits for those who have income between 134% and 400% of the federal poverty level. And down at the bottom of the slide, for those who don't keep these facts in their heads, the federal poverty level this year for a family of four is $22,050. So 400% of the federal poverty level this year is $88,200. And so you can see that the subsidies are available for low-income families, but at the top end, we're beginning to get into moderate or middle-income families as well. The subsidies are based on the cost of the Silver Plan, which I'll talk about in a minute, what the Silver Plan is. Family premiums are limited. Families will have to pay no more than 2% up to 9.5% of their income. And obviously, the higher your income, the more you are expected to pay in terms of the premium share. The greatest premium subsidies go to the lowest income families. And then there will also be limits on annual out-of-pocket expenses that are tied to income as well. And this provides a tremendous amount of financial protection for families because those out-of-pocket expenses now currently for most insurance policies are unlimited. There are no explicit limits on how much you can spend out of pocket under most current insurance policies. Finally, the bill expands Medicaid coverage nationally to cover everyone with incomes less than or equal to 133% of federal poverty. And this is a major expansion of the Medicaid program. The estimates are that of the 32 million Americans who will be newly insured as a result of the reform bill, that approximately half, or 16 million, will be eligible for Medicaid as a result of this change in eligibility and establishing a single national standard for Medicaid eligibility. Let's quickly talk about employer mandates, penalties, and subsidies, and I will go a little bit more quickly so that I can make sure that I get through my presentation in time. The bill will impose a fee on employers with 50 or more employees who do not offer insurance and who have at least one employee who receives a premium subsidy. The penalty's $2,000 per FTE, but it excludes the first 30 employees in these firms. It will impose a fee on firms that offer insurance but who have at least one person who receives premium subsidies in the exchange. And that fee would be the lesser of $3,000 per person receiving the subsidy, or $2,000 per total FTEs in the firm, excluding the first 30 employees. So firms above, with 50 or more employers, will have to either provide insurance or pay penalties. Firms with less than 50 FTEs are exempt from this mandate. In addition, there are subsidies to encourage, even though small firms and small employers are not required under the bill to provide insurance or pay penalties, there are subsidies to encourage small employers to provide health insurance or to help them with the cost of insurance that they're already providing. Those tax credits are available beginning this year for firms with less than 25 full-time equivalents and average wages less than or equal to $50,000. The tax credit for the next 4 years would be up to 35% of the employer's cost of providing insurance. The maximum credit is available to the smallest firms with the lowest average wages. And beginning in 2014, the tax credit will be up to 50% of the cost of insurance purchased through the exchange, but at that point the credit will only be available to firms for 2 years. And that applies both to current firms as well as new firms that are being created. The bill will result in the creation of standard health policies starting in 2014. And these standard health policies are the policies that will be both offered in the insurance exchanges as well as all new health policies, including those that are offered outside the exchanges. It establishes an essential benefit package that must cover at least 60% of the cost of essential benefits. This essential benefit package will be determined by a national commission that will be established for this purpose. Within this standard benefit package, there will be 4 tiers of coverage, and the tiers are the bronze, silver, gold, and platinum. The benefits covered by these 4 tiers are exactly the same. So these are literally the same insurance policies. The only difference in terms of their benefits, the only difference is that in the amount of coverage that the premium covers on average versus out-of-pocket spending. So the bronze plan on average will cover, the premiums will cover 60% of total expenses, and policyholders on average will pay 40% of total expenses out of pocket. And you can see as you step up to the platinum plan provides the highest premiums but the lowest out-of-pocket payments on average. 90% of the total cost would be covered by the premium. So this allows individuals to trade off between, do I want to pay more upfront in terms of premiums and less and reduce my risk of paying out of pocket. Finally, there'll be a catastrophic policy that will be available only for young people up to age, young adults up to age 30. And this is to encourage the quote-unquote young invincibles to buy health insurance. Those young adults who currently feel that health insurance isn't really necessary or necessarily affordable to them. All policies will have to limit out-of-pocket spending to $5,950 per year for individuals and $11,900 for families. And I mentioned this before. This is a provision that will provide enormous financial protection to people who have high healthcare utilization in a year. These limits will be lower for families below 400% of federal poverty level. All policies must guarantee issue and renewal, and they must eliminate annual and lifetime dollar limits on benefits. It requires that all the plans also, all new plans meet these requirements in 2014, except for existing plans that have been grandfathered. Obviously, another important aspect of the bill is the creation of the new insurance markets, the so-called health insurance exchanges, starting in 2014. The bill establishes for state-based insurance exchanges, one for the individual market, that is the non-group market, for individuals who are uninsured and qualify for premium subsidies, and then a separate exchange for the small group, that is for employers with less than or with 100 or fewer employees. The small group market will be open to large employers starting in 2017. And it also allows for co-ops and a quote-unquote public option to compete with private insurers. And the public option that was passed in the final bill is the multi-state nonprofit plans that will be offered or approved by the Office of Personnel Management. It requires insurers to offer only policies with essential health benefits, those that I talked about on the previous slide. Grandfathered policies with non-standard benefits can still be offered outside the exchange, but all of the policies offered in the exchange will have to be meet the requirements that I discussed in the previous slide. It will require that insurers price these standard policies using modified community rating, and the only factors that can be taken into consideration in establishing these modified community rates are age, tobacco use, family size, and geography. And there are limits on how much the premiums can vary according to age and tobacco use as listed in the slide. Finally, the bill retains the small group and individual insurance markets that currently exist, But those markets, and this is outside the exchange, those markets must follow the same rules that apply within the exchanges, and they must charge the same premium for the same policies that they offer in and outside the exchange. And this is to eliminate the possibility for cherry picking and cream skimming that could occur. So if an insurer chooses to offer a policy both in and outside the exchange, the premium must be, for the same policy, must be exactly the same. Finally, let me turn to the impacts on Medicare. A substantial portion of the financing, as I'll discuss in a minute, for this bill comes from changes to the Medicare program and savings in the Medicare program over the next decade. But there are other significant changes as well to Medicare. Perhaps the most important is that it eliminates the Part D donut hole in the drug coverage benefit. Starting this year, for any beneficiary who falls into the donut hole, there's a $250 rebate. Next year, there will be a 50% discount on brand name drugs directly from the pharmaceutical manufacturers. And then over the next decade, the donut hole will be gradually eliminated so that by 2020 it will no longer exist. It eliminates co-payments for preventive services starting next year. So this is similar to the requirement for private insurers, or the prohibition against charging co-payments for preventive services that have been graded A or B by the U.S. Preventive Services Task Force. Another controversial aspect of the bill is the elimination of the differential between Medicare Advantage plans and Medicare fee-for-service. Currently, nationally, Medicare pays about 14% on average higher payments to HMOs relative to fee-for-service Medicare. The bill will eliminate that differential starting next year, and the phase out of that difference depends on the magnitude of the difference between the Medicare Advantage plan's payment and the fee-for-service expenditures in that geographic area. And you can see on the slide that the larger the difference, the longer the phase-in or actually the phase-out of this differential. The bill also reduces the growth rate in payments to providers except for physicians over the next decade. It introduces an adjustment for productivity increases, and it reduces the subsidies to hospitals that covered the cost of uncompensated care, what are known as disproportionate share payments. It freezes the income thresholds for paying higher Part B premiums at $85,000 per individual and $170,000 per couple through 2019, and it establishes these same income thresholds under Part D starting next year. Finally, for those of us who are not yet on Medicare, it increases Medicare Part A payroll tax for high-income earners from 1.45% to 2.35%, and it imposes a new 3.8% tax on unearned income beginning in 2013. And high-income earners are defined according to the slide. The financing of the bill, I'm not going to go into this in any detail because I need to wrap up, but basically the final scoring of the bill from CBO was that the total cost was slightly more than $1 trillion over the next decade, and that is being offset by reductions in the growth of Medicare and Medicaid payments, an excise tax on high-cost employment-based insurance, penalty payments by individuals and firms for not offering insurance or not being insured, a series of new excise taxes, including a tax on tanning salons, an increase in Medicare payroll taxes that I just discussed, which you can see is a very large source of revenue, and a variety of other revenue sources and offsets. The final impact is estimated by CBO to be relatively budget neutral. And of course, this has also been a source of controversy, whether or not the bill really is fully funded or not. So in closing, I'd suggest anyone who is interested in more detailed information, the single best website for information on the bill and the provisions can be found at the Kaiser Family Foundation website at www.kff.org. I thank you very much for your attention today, and I'm happy to turn it over now to Q&A.
Well, thank you, Jerry. We have about 30 minutes for questions. And again, if you have a microphone, you can raise your hand by clicking the hand under the participant box, and we will call on you to ask your question. And if you don't have a microphone, simply type your question in the text box. And I see we already have a couple questions. The first one from Gary. Gary, would you like to answer the question right now?
Yes. So Gary says, I think correctly identified that increasing coverage and subsidies has to increase healthcare expenditures. And I think that that's right. If roughly 15% of the population is uninsured, and we know from a whole variety of studies that the uninsured on average spend about 50% less than insured individuals, even after controlling for differences in health status, providing health insurance coverage will almost certainly increase healthcare expenditures in the short term. I think that the objective and of course the goal of attempting to provide nearly universal coverage is that in the longer term that cost should increase less rapidly if people are insured and receiving care on a regular basis rather than on an episodic basis. But I don't think that anyone has predicted that healthcare spending in the short term is going to go down as a result of healthcare reform. Karen, would you like me to go to the next question that's been listed?
Yes, please. Sorry, I had a microphone issue. Yes, we can just address the questions as they are. Dan has posted a couple questions. One is the California state law requiring HMOs to already pay out at 85%. I know that there is a California law specifying medical loss ratios, but the federal law applies to all insurers, not just HMOs. And in California, we have this unique situation where we have one set of regulations for managed care organizations, specifically Knox-Keene licensed organizations, and then another set of regulations that are much less specific and much less restrictive for all other insurance. So I think the federal law will still be more proscriptive than current California law. John Eldon, I'm going to skip over Dan's question, next question, and go to John's. I'm not sure I know the answer to Dan's next question anyway. John's question about the financial incentive to for people to basically lead healthier lifestyles. There are many public health and health promotion activities that are contained in the legislation that I haven't had time to go into today. But I think that it's an excellent point, which is that providing health insurance alone does not necessarily provide an incentive for individuals to lead healthier lifestyles. What it does is it provides financial protection against the high cost of health care. And in the case of individuals with chronic illnesses already, it provides an incentive to seek appropriate care
rather than to delay care and allow their conditions to get worse, and all of the adverse health and financial consequences associated with that. But I think that we still have a number of initiatives that are important to encourage healthy lifestyles, and the bill, in terms of providing universal coverage or nearly universal coverage, does not necessarily address all of these issues directly with financial incentives. Joanne's comment, again, I'm going to skip over Dan because I want other people to have an opportunity. Joanne's question is about the college student insurance plans and how they'll fare. That's a good question that's come up before. I don't know exactly the answer, but most colleges and most universities require their students to provide evidence of insurance or to on their parents' policies, or to purchase a student health plan, which is generally not a tremendously comprehensive plan, but provides pretty good coverage for students while they're in school. My understanding of the bill is that those plans are eligible to be grandfathered, and my expectation is that more students are likely to be eligible for coverage under their parents' policies and to continue to be eligible, but that students will and families may still see the benefit of purchasing student health insurance. So I expect that market, although there may be an impact, I don't think that those plans are going to go away. They're affordable because they're targeted to a relatively narrow pool of young, relatively healthy individuals, and that's why those policies are fairly affordable. Leah is asking about the likelihood of state-initiated political lawsuits. Well, as you know, and I alluded to earlier, obviously, I think that there are 28 states, if I remember correctly, that have lawsuits that are pending. And I think this morning there was a news item that said that at least some portion of those lawsuits are likely to move forward. I'm not a legal expert, so it's difficult for me to comment on the likelihood of those being successful. But my understanding is that most of the challenges deal with the ability of the federal government to legislate and to require states to comply with the legislation. I think my understanding of constitutional law is that it's fairly well established in our legal system that the federal government can regulate commerce, and I think that the Commerce Clause of the Constitution allows the federal government to regulate health insurance. My honest opinion is that this is largely a politically motivated effort to delay implementation with the expectation that a change in Congress might lead to the repeal of the bill. But I think that that's what would be necessary. I don't think that these lawsuits necessarily will be successful, but I do think that as a delaying strategy, that if you hope that Congress becomes majority Republican, and more specifically that there's 60 votes in the Senate to overturn this bill, then if that's your strategy, then trying to delay the implementation or fight it might be part of that overall strategy to overturn the bill. The next question is relatively, let's see. The next question deals with Medicare Advantage and the 14% differential. Yeah, the 14% differential is not attributable to the difference in the patient's conditions. This is after controlling for that. Medicare risk adjusts its payments to Medicare Advantage plans, and in fact, in general, Medicare Advantage enrollees are, on average, less ill than the Medicare fee-for-service population. This difference goes towards additional benefits. It covers the cost of prescription drugs and other services that are not part of the Medicare benefit package, and basically represent a redistribution of benefits from individuals in fee-for-service Medicare to people in Medicare Advantage. People in Medicare Advantage are getting additional benefits at no additional cost to them, but the additional cost is at least in part borne by other Medicare beneficiaries in fee-for-service. And I think that that's the reason why this is being eliminated. This is, I think, a question of equity and providing free benefits to one group of beneficiaries at the expense of the other group. Brennan's question deals with the VA and how does the VA fit into it. The VA largely continues to operate the way that it does, so health reform is not directly affecting the VA system. But your question also is, can they choose one set of benefits over the other? I don't see anything and have not seen anything in the bill that changes the fact that many vets, once they reach retirement age, or I should say age 65, can, first of all, they're eligible for Medicare. And we know from many studies that have been conducted over the years that vets who are also eligible for Medicare move back and forth between the two systems. I don't see anything in the bill that changes that. The next question deals with the elimination of cost sharing, and that elimination goes into effect this year. It goes into effect this year for policy years beginning after September 23rd. So all current insurers, that they're not required, the bill does not require them to cover preventive services, but if they do, starting after September 23rd, when the new policy year starts, and of course most policy years start January 1st, so effectively January 1st, insurers that currently cover preventive services will no longer be able to charge copayments. I don't know the entire list of preventive services, but they are the things that you are most common. I mean, that would include Pap smears and mammograms, but I don't know the entire list of preventive services that are graded A and B. But they are things that are commonly provided by insurance companies. Okay, so I'll come back to Dan since he's now. I don't know how profitable Medicare Advantage patients are relative to commercial insurance patients with regard to the capitated group. So unfortunately, I'm not familiar with the financial arrangements and haven't seen good data on that. So I really can't address that question. Paul asked, Paul's asking about whether there were items that did not make it into the bill. Well, That's a great question, because I think that an argument could be made that there are many things that didn't make it into the bill. A piece of legislation like this, that as complex as it is, still has many other aspects of healthcare financing that aren't addressed. I would say that, in my opinion, one of the things that the bill does not address, and it was alluded to in an earlier question by, I think it was the first question by Gary, the bill does not address in a very strong way the rising cost of healthcare and the ongoing reasons for increasing healthcare expenditures in the United States. And I think that that was a political decision. It was a deliberate omission. I think that this bill, if the goal was to achieve nearly universal access to health insurance coverage, trying to tackle that and tackle all of the sources for our rapidly and ongoing increases in healthcare expenditures would have been impossible. It was barely possible to get this bill passed. If the bill had also attempted to deal in a very meaningful way with reducing the growth in healthcare expenditures, I think the bill would not have been enacted. So I think that we've kind of punted for the immediate future on tackling the issue of rising healthcare expenditures. And I do think that we are going, over the next decade, are going to have to come back and deal with that in a serious fashion. But this bill has some provisions, but not nearly enough. Risa's question deals with a push to use cost effectiveness and comparative effectiveness to reduce costs. Well, that's a political hot button issue right now as well. If you look at the bill, cost effectiveness was explicitly excluded from the bill because Republicans did not want the government to be making decisions on the basis of cost, and did not want, quote unquote, rationing of care based on cost. And so I think the compromise was the inclusion of comparative effectiveness, which focuses solely on differential outcomes and not on the cost of achieving those outcomes. I think that this is a societal issue that we're not quite ready to tackle yet, and it's related to my response to the previous question, which is that we're not prepared yet to make hard decisions about tackling the ongoing cost increases in our healthcare system. And I think that we will have to tackle that within the next 10 years. The next question from Irene deals with undocumented immigrants. I think that the bill obviously excludes them. And so it means that, in a sense, the barriers that currently exist will continue to exist. But having said that, there are explicit provisions in the bill that will benefit undocumented immigrants. Specifically, there's a major increase in the subsidies to federally qualified health centers in the bill over the next decade. And many of these centers are a primary source of care for the uninsured, which includes the undocumented. So I think the increased funding for those centers will actually expand coverage opportunities, or service, I should say, opportunities for the undocumented, but not in the form of health insurance, which is portable and is comparable to that which will be available to other low-income individuals. Thanks for your compliment, Dan. Tracy's question, the implementation of ACOs is that practical and feasible as outlined in the bill? I think that what the bill does is it sets up funding for demonstration projects, and frankly I think that it's over the next decade we're going to be figuring out how to make accountable care organizations, how to actually get them up and running. So the bill will provide support for that in the form of grants and funding for pilot projects. But I think that there are a lot of challenges, and the biggest challenge is who gets paid, and in other words, who's the original party at risk, and then how are those payments then divided with all of the other parties who would provide care. There are a lot of challenges in trying just to figure out an answer to that basic question with regard to accountable care organizations.
Are there any more questions at this point? Otherwise, Jerry, is there something you would like to add?
There isn't really anything that I'd like to add at this point, but I'd like to thank everyone on behalf of the school for participating. This is, I think, a wonderful opportunity for us as faculty to engage with alums and with the community. I'm really happy to participate in this process today, and I'd like to thank everybody for their thoughtful questions. This has been a really good opportunity to interact.
Well, we'd like to thank you, Jerry, for a great presentation, and thank you to the participants for all the questions. We'd love your feedback since we are just starting these webinars, and thank you for your positive feedback. And yes, UCLA School of Public Health will continue this effort. You can contact our office just to give us your feedback, but please mark the next lunch lecture in your calendar. We will continue the conversation on Wednesday, October 20th with Dr. Toni Yancey. Her book, Instant Recess, Building a Fit Nation, 10 minutes at a time, is just out. She argues that we need a different approach to exercise to solve the obesity epidemic. Dr. Yancey's webinar is scheduled again Wednesday, October 20th at noon. We hope you can join us and wish you a great rest of the day.